All right, everybody, welcome back to the channel. Let's hop right in and talk about pain. Your pain, my pain, chronic pain, back pain, neck pain, shoulder pain, leg pain, knee pain. Let's talk about chronic pain. Not the guy, I'm sorry, so if this is you out there, you can shut off the video. I really don't care. So if you tweaked your knee yesterday in the gym and you felt it churning, you can watch my video by all means, but it's not really applying to you at the moment. This is more for the people that have lived with the same chronic, it's just that ice pick right there. It's, oof, that right side of my back today is just, really hurting me and I don't feel like doing anything. Those are the people I want to speak to because we need to find out what it's really like what's really practical out there that helps you, that can help you based on the science. And when I say based on the science, we're talking about like the actual rules of neurology, biology, physiology, anatomy, not the uh, whatever bias funded, peer reviewed, evidence based, evidence guided, randomized controlled trial that will show whatever needs to be shown at the time and not even consider the phenotype, age range, demographic, habitus, um, healthy user bias and or not healthy user bias that leads to the conclusion of a paper, which ultimately will always say more research needs to be done. I mean, just look at a lot of research. You can do all your compiled, literature and pick and choose what you want depending on the methods. But we're certainly not going to be looking at that today because I've, looked at it all for the last 5 years, depending on, the circumstance. When I say looked at it all, I know what that could sound like. But, when it comes to like back pain and leg pain and neck pain and articles, and to find out like why is this one thing maybe working for somebody and this other thing not working for that same person, and then the same person comes along with the symptoms and they try and say, well, that didn't work for me. Well, let's address that in this video. Let's just go after that because I think people deserve to know the truth when it comes to the actual scientific principled reasons why you are either in pain or possibly managing or your pain or not being in pain. And so there's a few key takeaways before I even begin. Number one is if you've had pain for whatever amount of time, I don't know, 5, 10, 15 years, and you ended up having a surgical intervention that fixed you, that's great because newsflash, here we go. The only way to really get fixed once you have that deformed tissue, once the injury has gotten so old and so much fibrotic scar tissue is at the level of injury, usually neck or back pain related, arthritis in the knees, and why you see so many elderly folks getting knee replacements or hip replacements. I mean, let's not beat around the bush. If you're listening to what I'm saying, acknowledge that these injuries occur. There's a lot of scar tissue and damage and arthritis and bony changes that happen around the joint. These thinning spaces, these osteophytes, and these osteoblasts or clasts. The blast would be, because of the destruction of, or sorry, because of the buildup of the bone, it becomes very deformed and overgrown, where class would be like actually withdrawing of the bone and you actually have like less bone, but that's usually something that's very pathologic in nature, as in it may even be cancerous. It's completely not normal, where it is very normal, right? They say normal as we age to potentially develop these arthritic like changes where bone on bone takes place in a lot of these joints, really because of probably an underlying issue, whether it be a parathyroid hormone issue where bone was just building up high levels of calcium in the blood that never got diagnosed, whether it was an injury that was so severe that the bones, because your body is so smart, tried to like stabilize the joint, right? Because stability over anything else to prevent the instability, because then the joint will separate, ultimately like break in half. Or if you're in your spinal column with a degenerated joint, it will again very wisely try to stabilize so that the hypermobility of the spinal column does not lead to spinal cord injury and severe type of neurologic compromise and damage. So I want you to understand those principles. And again, if you've had a surgery and it was successful and you felt like you recovered fully from it, that is awesome, because that is where the miracles lie in the sense of healing, in the sense of being fixed. They are surgical interventions with very desirable outcomes to where you have your full quality of life back, which takes me to somebody who's suffering with back pain. And I'm going to use myself as an example, where I used to run all the time. I used to run just about every day. I loved running. a lot of doctors, whether it be the neurosurgeon who did perform my back surgery in September of 2023, told me not to run. A lot of traditional, people, oh, don't run on the pavement. It's bad for your back. Don't run on the pavement. It's bad for your joints. I personally feel that this is true if you have a pre-existing injury, but the hormesis aspect of building resilience, if you don't have that kind of injury, is actually going to be very smart. There's a reason why a lot of people well into their 60s and 70s, maybe even older, continue to run, and they run outside and they have thin, lean bodies. Not to say this is healthy or unhealthy. What I'm saying is that it shows that they are very specific exercise, not dependent, but the dose response to their exercise creates a phenotype of somebody who looks like they do that, and that is because they train outside. That is because they're pounding the concrete, so to speak. And I have found that when other doctors have also told me, well, just walk. Walking is low impact. Nowadays, even when I walk, whether it's 2 miles, whether it's 6 miles, it is very hard on my lower back for a lot of the same reasons that running would be. As a matter of fact, running with sort of like not an antalgic, with an anterior lean where my back is mildly rounded, seems to actually take a little bit of pressure off my back, as opposed to sort of walking and heel striking. That leads to more bone impact and bone strain and stress on the joint. So it's little things like that where walking isn't necessarily better than running, and running isn't necessarily worse than walking or better than walking. It's you really have to begin to test what not just works for you, but building that hormesis, that resilience. And that's another topic that we should just kind of quickly discuss right now. And that is, when is exercise, when is purposeful given inflammation through exercise going to be beneficial to you, the person who's in pain? And the answer is going to be any time that you don't feel compromised. I'll repeat that. When is inflammation through exercise to the joints to strengthen and build resilience in your body, in your spine, in your injured joint through exercise, right? Physical therapy is what I'm kind of talking about, like that rehab, active therapy. When is that appropriate? It's when you don't feel compromised. And you have to begin to, when we say things like know your body, we are saying you have to understand that, like, hey, the last time I did this, I got hurt. The last time I did this, I felt a tweak in it and it wasn't good. Like, especially people with bad backs. Once that lower back goes out, you're leaning away from the pain, you feel it in your buttock, your sciatic's flared up, whatever the case, even if it's just dead, center. Those people know, like, they want to lay down, they want to put their feet up on a bench, or they want to lay on their stomach and just completely decompress. It really hurts to move around. It's terrible to walk. Sitting to standing is the worst. Sitting for a long time really makes everything uncomfortable, and that is because they've compromised their disc. Now, is it because they just compromised their disc? No, I mean, there's a lot of levels to that. Ligaments, tendons on this more superficial, but the ligaments deep within, they're packed around these oblique, diagonal-like looking annular fibers of the disc. They are packed with these sinovertebral nerves that have tons of proprioceptive but better word would be nociceptive fibers packed within the ligaments. And these like tiny little woven disc protecting or disc censoring pain receptors say, oh my God, you've gone beyond anatomical integrity. They've now hyperstretched. They've opened up. They've opened up when there's a bad disc injury in the back. This could be anywhere in the spine, but typically in the lower back at L4, L5, L5S1, the typical ones. And they stretch, which leads to a bulge, or it stretches really badly, and then some of that nucleus jelly donut comes out of the disc, right? And that leads to a herniation. When the fibers, the sinovertebral nerves, and the rest of the nociceptive receptors of pain receptors in the body feel this, it is debilitating. Why? Not because it's the worst injury in the world. It's debilitating because your body has now said, oh my God, my spinal column is compromised. And then what it's going to do is try its best to stabilize. So the way that happens is, as Stu McGill would famously say, it gristles and it starts to form scar tissue. And fibrotic sort of healing, band-aid, stabilizing of that disc or that area of the spine. And people who try to sort of push through that too soon are just going to find that it gets flared up too fast. And here's the reason why. When you're at rest, there's something called the glymphatic system. They call it the glymphatic because it's like the lymphatic. It's like this cleaning, filtering, rehabilitative system. But instead of it being like a universal vascular kind of thing, it's the glial cells in the brain, and it works to what's the word I'm looking for? Um, oh, the amyloid plaques that are associated with things like neurodegenerative disease and Alzheimer's, they can help clean those and sort of filter and regenerate um, only the good stuff, right? Only the good neuroplasticity sort of will come back while you're awake. Exercising neuroplasticity and healing your brain, or I should say, getting good stimuli to your brain to retrain your brain comes during the day, but the lymphatic effect during the rest and repair mechanisms at night is where all the real healing occurs. I mean, anytime you have cortisol, adrenaline, fight, flight, stress, and strain in the body, because everyone's talking about in like the functional medicine world, right? They're like, reduce your cortisol, reduce your stress, try deep breathing, in through the nose, out through the mouth, try yoga. I did stretching and yoga and mindfulness, and I healed. It's only possible when you get the full rest and repair, the full benefit of being in deep sleep. Why do you think somebody like me is now very much an advocate of taking certain peptides, like an HGH secretagogue, at night so you can get deep sleep, which leads to tendon repair, ligament repair. I wouldn't say like disc repair, but like all tissue repair is optimized at night. It's why I'm telling you, you have to get good sleep or you will never repair. And that leads us to when being awake. When you finally don't feel apprehensive, when you finally don't feel compromised, you can then do the inflammatory, hormesis-like events, exercise, whether it's neuromuscular dynamic stabilization, whether it's, the McGill Big Three, right? The bird dog, the glute bridge, and the curl up, whether it's going to the gym and beginning to slowly challenge your body and build that resilience, that active therapy, that active progressive therapy that then leads to full blown, weight bearing through motion exercise, whether it's running or squatting. When you can tolerate that without the apprehension or without feeling that joint compromise, then you are as stable as can be, which during pain management will be the highest level of what we would refer to as fixed in my world. And there are ways to achieve it faster. Chiropractic adjustments done right and well will be the gateway to having that accomplished as fast as possible, but also even then feeling most comfortable to be able to sleep the best. And then you can think about what other performance enhancers you want during even sleep, HGH, or when you're awake, BPC 157, TB 500, repair, systemic repair, repairing the actin like filaments around these cells and the proteins that go to repair cells. That's what TB 500 does, as opposed to just the angiogenesis and blood vessel sort of support and other, I don't want to call it anti-inflammatory, but the, VEGF, body protective compound, things that BPC 157 can reportedly do, but it's not going to reattach your tendons. That's for surgery. It's not going to reattach your, tendons would be the same thing, like muscle to muscle and like a rotator cuff thing where everybody talks about. Again, it's an enhancer to help the inflammatory process be as robust as it can be. And that is how you do it when you're awake, and it's only aided by the effective sleep you get, and now we have given you the reasons why. So please, when you are out there and you are starting to see people doing crazy workouts and say, this healed my back, just do yourself a favor and look at the person making the video and see where they're really coming from. And then when you start to look at people that are a little bit more identifiable to like the age range that may be applicable to you, because we usually don't see these kinds of injuries with people until they're like in their late 30s, and that's early, when usually in their 40s and then through their 60s, because the chronicity of the insult, the chronicity of the deformed tissues has finally caught up to where it is now a very important, part of your daily pain management. And, you could want to do, we hope that you're watching this video because you don't want to be on gabapentin, because you don't want to take Advil every day. You don't want naproxen. You don't want to have meloxicam. You don't want these drugs. God forbid, like you don't want opioids. Like you don't want these things because there's nothing good that comes from any of them. Do I take some baby aspirin, or once in a great while will I, knock down, an acetaminophen, like if I need it? Like, of course. I mean, if you don't, you're just like robbing yourself. I mean, we all get sick. We all get tired. We all get headaches. We all get body aches. There's no reason why you can't like cut the severity of it with some of these, pharmacological, interventions that have been around. But what you really want is these habits that you can, go at naturally with no or very near next to no risk whatsoever. That maybe they cost a little bit more money. Yeah, I mean they do. I mean it's because they work and because people, really, want this stuff. Like I don't know, supply and demand. Like you've got to be able to justify. Okay, I'm going to prioritize this so I can get back to doing what it is I love at the highest level. I know I say that a lot, but I wanted to put this video out here today because if you understand how to prioritize it and you get away from some of the stuff maybe you've been doing that's setting you back or not getting you to where you want to be, come back to this video and share it with some people that may really need to hear it, and ask any questions you want. But looks like I've run out of time because I really do need to open up the doors to the office. So thanks everybody. It's Dr. Perlman.